Good afternoon, everybody, and thank you all for attending today's webinar, sponsored jointly by the ATS Assembly on Allergy, Immunology, and Inflammation, AII, and also jointly by Assembly on Clinical Programs, CP. I'm Tetsuro Maeda from AII Web Committee, a junior faculty at the University of Alabama at Birmingham, Division of Pulmonary Allergy and Critical Care Medicine. I'll be moderating today's webinar entitled Home Oxygen Prescription and Delivery Systems. This webinar will include presentations by 3 excellent expert speakers with extensive contribution in this topic, discussing clinically important topics surrounding home oxygen therapy. I am personally very excited to hear the presentations, but please allow me to introduce the speakers first and make some housekeeping announcements. Okay, the first speaker is Ms. Susan Jacobs from Stanford University, Division of Pulmonary Allergy and Critical Care Medicine. She is currently a research nurse manager at Stanford and is the first author of the ATS Clinical Practice Guidelines for Home Oxygen Therapy for Adults with Chronic Lung Disease, published in 2020 in the Blue Journal. She is also a recipient of 2025 ATS Public Service Award. Ms. Jacobs will provide overview of scientific basis for oxygen therapy in chronic respiratory diseases. Then the second speaker is Mr. Michael Hess. He is a registered respiratory therapist and pulmonary function technologist who is currently Senior Director of Advocacy and Regulatory Affairs at the COPD Foundation. He has been very active in patient advocacy, awareness raising activities, and education in oxygen therapy. Mr. Hess's presentation will include live demonstration of how different types of oxygen delivery devices operate. And then the third and final speaker is Dr. Donna Abson. She is a professor of internal medicine at the University of New Mexico, Division of Pulmonary Critical Care and Sleep Medicine. She is also a medical director of home respiratory care team at the New Mexico Veterans Affairs Healthcare System and co-authors the previously mentioned ATS Clinical Practice Guidelines for Home Oxygen Therapy, among many other contributions in this topic. Dr. Abson will cover practical aspects of home oxygen therapy prescription, including insurance coverage and common challenges. Okay, and housekeeping announcements. The session will be recorded and posted on the ATS website. We plan to first go through the presentations and then at the end have time for discussions and questions by the audience, approximately hoping for 15 minutes or so. So if you have questions, please use the Zoom chat function to enter your questions at any time. We will hope to address all the questions at the end. Okay, with that, I will ask first Ms. Jacobs to share your slides and begin the talk.
So thank you for having me. Great to be here and talk about oxygen from all, excuse me, from all aspects. So I'm happy to be joined by my colleagues. And my task in this very brief time will be to cover an overview of some of the evidence we have for resting hypoxia and ambulatory hypoxia in some chronic respiratory diseases, a brief review of the criteria for initiating oxygen therapy, and then some review of the clinical significance and outcomes that we see with patients with chronic hypoxemia or hypoxia. So just to set the stage for how the first oxygen clinical practice guidelines came to be, we had some background awareness around late 2017, maybe even as early as 2015, where we just had more oxygen problems reported by patients. So this precipitated the need to get more data and have a workshop report to really hear from all stakeholders, patients, providers, researchers, payers, and industry, what the gaps and problems were. And that really set the background for developing some clinical practice guidelines to guide clinicians in having evidence for what they were prescribing for our patients. So these guidelines, this was a 2-year project. This was a project application within ATS. It included a multidisciplinary panel, which it did include methodologists and a medical librarian. So the target groups for the guidelines specifically was the group of patients with chronic obstructive pulmonary disease or those patients with interstitial lung disease. We asked 6 what we call PICOs. These are clinical practice questions, and PICO stands for population, intervention, the comparator, the comparison, and the outcome. So these questions were developed as part of a Delphi process where, as an expert panel, we repeatedly developed questions and then ranked them for relevance and interest and evidence need, and came up with 6, which is really about the limit that you should address in a single guideline activity. We looked at outcomes of mortality, quality of life, health-related quality of life, and physical activity. And this was a systematic review by our librarian and methodologists using what we call the GRADE methodology. This is a very set grading of recommendations, assessment, development, and evaluation. And this methodology really ensures assessing the certainty of the evidence and the strength of our recommendations. And it also integrates what we consider the values and preferences when making these decisions. So I would say the last bullet point here is that the evidence that we found varied in availability and quality, and it actually limited the strength of some of our recommendations. So these were the questions that we asked for patients who have COPD or chronic obstructive pulmonary disease. So question 1, should long-term oxygen be prescribed for adults with COPD who have severe chronic resting room air hypoxemia? And this was defined as an oxygen saturation equal to or less than 88%. So after review, the recommendation was that these patients, we do recommend prescribing long-term oxygen therapy for at least 15 hours per day. And this was a strong recommendation with what we considered moderate quality evidence. The second question was, should long-term oxygen therapy be prescribed for adults with COPD who have moderate chronic resting room air hypoxemia? And that we defined as a saturation of 89 to 93%. And this recommendation was negative. We did not find evidence that there was benefit. And in fact, in the United States, these patients wouldn't qualify for supplemental oxygen. The third question we asked was, should ambulatory oxygen be prescribed for adults with COPD who have severe exertional room air hypoxemia? And again, we defined that as 88% or below. And this, we found less evidence, but enough to make a recommendation. It was a conditional recommendation with what we considered moderate quality evidence that we would recommend prescribing, or you'll notice here, it says suggests. So suggests is because of the quality of the studies that we reviewed. So we suggested prescribing ambulatory oxygen. And then we did place a high value on health-related quality of life when measuring and assessing the evidence. We placed a high value on quality of life over, for example, cost or even the burden. So that's, we can talk about that as we go through these. Then with the patients who have interstitial lung disease, that body of evidence was reviewed and two of the same questions were asked. Should long-term oxygen be prescribed at rest for those with chronic hypoxemia? And there was very little evidence. And in fact, most of the recommendation was based on extrapolating the outcomes from the studies done with COPD patients. So we had a strong recommendation, but very low quality evidence. And then the fifth question was, should ambulatory oxygen be prescribed with exertional room air hypoxemia? And again, we had very little evidence. There were not a great number of studies to include in the review and the assessment. So again, it was a suggested recommendation, a conditional with low quality evidence. And then we did include a question 6. Should portable liquid oxygen be provided for adults with chronic lung disease, prescribed continuous oxygen flow rates of over 3 liters continuous flow per minute during exertion? And this really came about because of the, it really was an expert panel recommendation of our experience with high flow patients having very little access to portability. So in these patients, again, there were very few studies that we could even evaluate that tested this type of oxygen. But based on the panel's expert opinion and some evidence, we had a conditional recommendation, but very low quality evidence. And lastly, this was a best practice statement, which seems kind of sad to me that we have to include this as a recommendation, but we did kind of include this as an expert opinion to have within this guideline that all patients prescribed home oxygen and their families should receive, of course, training and instruction on all the equipment, safety, and completely have full education provided to them at the time of prescription. So to kind of put these together, for severe resting hypoxemia, both COPD and ILD patients, we gave a recommendation that yes, based on some really older studies, 2 COPD studies done in the early 80s that did document a survival advantage in a controlled trial. So we really had to extrapolate that body of research and apply it to our ILD patients because there really are no survival studies for that population. So it was a strong recommendation for both with chronic resting hypoxemia. Moderate, we didn't ask that question for our ILD population. And for the COPD population, it was a conditional recommendation against because there was no benefit. And again, as I mentioned, these patients wouldn't qualify except if you were with pulmonary hypertension in group 2. You can have oxygen prescribed with an 89%. And then we come to what I think is really the area of need, severe exertional hypoxemia. Neither population had strong evidence, so both were conditional and with low quality evidence. And it's an area, as I'll talk further, I think really needs a lot more examination. And then high flow needs, we made that conditional recommendation, but really without evidence, it was really an expert opinion consensus. So what about some data since then? So these guidelines were published in 2020. There's not been a lot since then, but I think the trend has continued. So for severe resting hypoxemia, we really haven't had huge added body of research, but there was what we call the REDOX study, which confirmed non-inferiority when using either 15 hours a day of continuous oxygen or 24 hours. They didn't find that one was inferior to the other. So the recommendation really hasn't changed dramatically, that the evidence still supports continuous oxygen with a minimum of at least 15 hours a day. And again, it should be tailored to the patient. Some patients will need that 24 hours, but the REDOX study specifically addressed this in COPD patients only, and found no difference between those two lengths of time. And moderate, there's really been no change. We don't recommend it. And now with the severe, with people who have isolated exertional hypoxemia, there still is lack of consensus. I would say there's mixed results, there's contradictory results. The outcomes with quality of life, functional status, like activity level, survival, there's really lack of consensus. And I think many studies are really now showing more of the burden that patients deal with and the psychological and physical burden. So the American Thoracic Society, as you remember, we have a conditional recommendation with low quality. The British Thoracic Society does not recommend it in this situation. The Thoracic Society of Australia and New Zealand is a weak recommendation, but it's only if they have benefit documented with a 6-minute walk or with shortness of breath. And then isolated nocturnal desaturation. There was an INOX trial that was negative for patients that had only isolated nighttime desaturation and found no difference in survival or progression of disease. So none of the societies ATS did not make a recommendation in our guideline, but others are not supporting that. And I wanted to say that this is this summary here is really adapted from a publication that came out in the in JAMA that really is a nice person-centered review of some recent evidence and recommendations. So for ILD, similarly, no really dramatic new studies to change our recommendation for Chronic resting hypoxemia, yes, they should be using oxygen. Exertional, no change. And now we're seeing a few more studies, and I'll review one at least. There are mixed results. Some patients report great benefit in breathlessness, activity level, etc. Others do not. And the burden, which includes, of course, the stigma and I'll point that out on another slide. But the burden versus the benefit is becoming more, I think, we're more aware of that with our patient data that we're getting. So the British Thoracic Society is against recommending in this situation, but state that some patients may benefit. In the Australia, New Zealand is a weak recommendation, and they only prescribe it in a blinded walk. So they get sham oxygen versus room air, and they need to document an advantage with the oxygen on their walk distance or breathlessness. And this was no changes for nighttime. Pulmonary hypertension, again, this is from Angela Swen's paper and others, that pH gives a little added, they're group 2. When we prescribe oxygen, we take into account pulmonary hypertension and the signs of cor pulmonale. So again, there's very little research done just on this population. The early trials did include some COPD patients that had cor pulmonale, but very few studies have been done on any other pH etiologies. So I do want to just point out kind of a trial that shows us, the challenges of doing oxygen research, to really tease out this question of who benefits from exertion only, these patients that have isolated exertional hypoxemia. So this was Yet Kaur and her colleagues did an ambulatory study with fibrotic interstitial lung disease, triple blinded. So this was sham controlled. They gave patients a POC, identical, one with room air and one with oxygen. 30 of them with interstitial lung disease were randomized to either group, 12 weeks. The primary outcome was it feasible to do? And what were their changes in 6-minute walk on room air between week 4 and week 12? And also they looked at a lot of health-related quality of life outcomes and an activity diary. So this is, as I'm in research, this is the world I live in, is enrolling trials. Well, you can imagine the challenge of this trial. And they assessed, over 600 patients to come out with their 30 that they were able to randomize. So I just want to remind everybody that the immense challenge and undertaking that it is to really proceed through these studies. So their outcomes were negative. They had found no significant difference in 6-minute walk distance, the resting or lowest O2 sats, breathlessness and fatigue on room air. They were tested on room air at week 4 and 12. There was a slightly higher, this is a cough questionnaire, psych domain score for the oxygen group, but otherwise in other domains, depression, anxiety, dyspnea, they found no difference. They actually did some blood biomarkers where there were no difference. And they found that the oxygen group was actually a bit, less active than the sham group in terms of their time spent with moderately vigorous activities, defined as over 3 minutes. And their daily step counts were no difference. And the thing that really hit me was that they only used their device an average of 40 minutes a day over 12 weeks. So we need to understand better what the issue is there. So this, again, is the balance that I referred to, the potential benefit. Of course, we hope for better breathlessness, less breathlessness, more activity, protect cardiac from pH, mobility, travel. But what we hear from patients is, of course, stigma, embarrassment, and they may actually be more socially isolated because they don't want to go out with a cannula on. Confirms their disease, so psychologically it's a lot. Equipment, safety, and then the real challenge is, even though we may see a positive benefit on their 6-minute walk, for example, they walk further on oxygen, they have less breathlessness. Does it translate to their home activities? And can we measure that in their real home environment? And that's a challenge. And then one other study I just want to point out, because I want to remind everybody that no 2 patients are the same. And I think that we have to do more in precision medicine to see which patients benefit and what are the predictors. So this study took two populations, one of COPD and one with IPF, idiopathic pulmonary fibrosis, both with similar baseline PFTs, age, demographics, did a walk, and you'll notice that the IPF group desaturated lower, significantly lower than the COPD group. And I must tell you also that they have a more rapid rate of desaturation. But the interesting thing, the IPF patients reported lower breathlessness scores than the COPD patients did. So I think when we talk about trying to personalize it and ask our patients, do you benefit? Are you less short of breath? We have to be aware that some patients may not sense that low oxygen. They're different. We don't know why some patients have a different sensation, but we do know that the oxygen needs varies between different patient populations, but we need to understand it better. So this, I think, this is published, and in the references that you'll have, we do prescribe oxygen in the United States for patients that hit 88% or lower. And we do test them with oximetry and a 6-minute walk and determine with 3-part testing, resting on room air, exertion on room air, and then exertion with oxygen. And that's how we get our patients qualified for oxygen. And of course, we hope that when we prescribe oxygen, which I think my other colleagues will talk about, that we ask the patient if they're working, if they have 50 stairs, if they live alone, frailty, and that sort of thing, to try and personalize their oxygen. Certainly, we want to prevent long-term effects of patients being exposed over time to low oxygen. And we find some patients are willing to go out with their portable oxygen concentrator that may not be adequate because it's portable, but they may be spending more time with low oxygen levels. And these are all just a summary of the outcomes that we certainly want to prevent. We don't want patients exposed chronically to long periods of low oxygen levels. So in summary, we know there's a survival benefit for giving patients who have hypoxemia at rest. So we should definitely educate those patients. And the second thing is we do need to have accurate testing. We do need to prescribe oxygen at least a minimum of 15 hours a day to prevent the long-term effects. And I would also say we need a lot more research to be done in the area of patients who only desaturate with exertion. It's really challenging to have an evidence-based recommendation there. I'd also say we really want that person-centered approach. This is one of a patient from our support group. And if we told her, you don't need to use your oxygen all the time, or you don't need mobility, she swims in the bay, the San Francisco Bay, travels to see grandchildren, still active with support group information and support, and swims. So her mobility, she trades off. She is okay with the burden because of the benefit for her personally, but it varies per patient. So that's our goal, is to really try and personalize and get more evidence. Thanks very much. I'll stop sharing.
Thank you so much, Ms. Jacobs. That was fantastic. We'll just, move on to the next presentation by Mr. Michael Hales from COPD Foundation.
All right. Well, thank you very much. It's interesting because Susan talked a lot about trying to judge the burden versus the benefit of this equipment. And it's something that as a respiratory therapist, I didn't really think a lot of when I was first getting into oxygen, the ambulatory oxygen space. And I actually had an RT, a more senior RT, tell me that's pretty common, because when we start our work, we put the flow meter in the wall, we hook up the tube to it, and we don't really have to think about it. But when people get out into the real world, they have a lot of other things to consider. And again, that's kind of where that burden versus benefit comes in. A few pieces of equipment here. I just want to point out that they're exemplars of the various types of equipment. This isn't to endorse a particular brand or anything like that. I will give one shout out to my good friend, Chrysalis Ashton, who is the Director of Clinical Operations for CareLink Medical here in Michigan, who facilitated loaning me this equipment today. But that's the only pitch you get from me today. So we start with perhaps one of the more common devices here. This is what's known as a stationary oxygen concentrator. This uses a molecular sieve that contains a material called zeolite that absorbs the nitrogen from the air and then funnels that remaining gas, the 21% oxygen, into a compressor and then provides that to the patient. Now, this is the benefit of this particular device is, this class of device, is that it does provide a continuous flow rate. Again, just like that, the flow meter you would get out from the wall in the hospital. You can see here, this device goes up, well, I don't know how well you can see it, but this device goes up to 5 liters per minute with a standard tube flow meter here. And you can hear it coming out, and you can see one of the downsides to this piece of equipment is, especially if I bring the microphone a little closer, it's fairly loud. This is not a quiet device. It kicks off obviously a lot of sound, and it tends to kick off a lot of heat. So people need to be fairly careful sometimes where they position this. They may put it in a particular room and use a lot of extension tubing to get around. People are pretty clever with coming up with adaptations, because then they worry about, well, is it going to get kinked, or is my dog or cat going to chew on it? I actually host a monthly support group, and that is a fairly common question of, how do I manage all of that tubing so that I don't have to keep moving this from room to room, and so on and so forth. So we then move over to the little sibling. This is a portable oxygen concentrator. As you can see, this is much more lightweight. I can't even imagine trying to hold that in the palm of my hand. This is a couple of pounds. And a good chunk of that is the battery component, which I can tell I'm not endorsed by a particular company because I don't even know how to pull the battery out of it. Anyway, there's a battery in here. Take my word for it. It works on the same principle of the molecular sieve with zeolite crystals, but obviously, since this is a lot smaller, it can't filter out as much gas, and it can't produce as much for patient delivery. So to compensate for that, well, I guess I'll go back a second. One of the other upsides is that it is a bit quieter. Different devices are going to have different ambient noise levels, but this is arguably a fair bit quieter than the larger device. To compensate for that lower delivery rate, what these devices tend to do is what's called pulse dose delivery, where instead of that continuous flow of oxygen coming out from the outlet, it will accumulate some and then sense when a person inhales through the cannula, and then deliver that at the beginning of inhalation, with the thought being that goes all the way down into the respiratory tree, and that's really where the effective dose is going to be. Again, the idea being anything that's not delivered during inhalation is going to be relatively wasted. There are physiological arguments to be made that it's important to have that reservoir with continuous flow, because it will build up in the sinuses and so on and so forth. But again, that's the concept behind here, and allows us to work with a much smaller filter. And again, you can hear a little bit of a hiss every now and then, because this one's not sensing a breath since I don't have a cannula on, and it is delivering that puff as it comes out. Now, the other thing to really keep in mind with these kinds of devices is they will also give you a setting, a numerical setting. In this case, this is set at 2, and this device goes all the way up to a setting of 5. You can hear it probably kind of revs up a little bit, and it's delivering a little bit faster, a little bit more oxygen there. Many people assume that that is the exact equivalent to 1, 2, 3, 4, or 5 liters per minute of oxygen, of continuous flow oxygen, and that is not the case at all. These devices are hypothetically similar to that. But a lot of people are told, well, you should be on 2 liters. You shouldn't ever change that, because there could be bad things that happen, or so on and so forth. So just leave it at 2. But as you might expect, somebody's oxygenation needs are going to change if they go from seated to standing up, walking around, being active, all the things that we tell them to do to stay healthy. And you may need to increase the delivery rate on here in order to keep up with that. Another complexity is each manufacturer has a different idea of what their setting should be. So you may have one manufacturer A, their setting of 2 gives you, for example, 15 milliliters of oxygen per breath. You go to company B, and they may give you 20 milliliters of oxygen. You know, that's just off the top of my head. Those aren't actual examples, but and so if you have this device and you have it on a set of 2 and you know that's what's working for you, and then for whatever reason you have to trade it out for a different device, and let's say you also try that with a setting of 2, that one doesn't seem to work as well, and now maybe the person is kind of wondering, am I sicker? Is there something wrong with the machine? So on and so forth. It's important to remember that that's really just a difference in the device itself. And you just have to, again, this is where that precision medicine comes into play again. You really have to configure that for the individual person using their oximeter and figuring out where their exercise patterns are and everything else. Finally, you'll, as you may recall, when this went up from 2 to 5, it got a little bit louder. It's working a little bit harder. And as with any other electronic device, the harder it's working, the faster it's going to drain the battery. And so as you're looking at these devices and reading the specs, and it will tell you, just like with a laptop or a phone or something like that, it will give you the ideal amount of time that a system will last, usually on the lowest setting. But the real world data are usually quite a bit different than that. And so, in the 2018 paper that I think it was the 2018 paper that Susan mentioned, a large majority of oxygen therapy users said that their device does not last long enough for them to be outside the home. I want to say it was around somewhere around 80% said that their activity was limited to 4 hours or less. And depending on where you are in life, that may be plenty of time, but it often is not, especially when we start getting into our final device here, the old standby for walking people around in the hospital. This is a compressed gas cylinder. With a continuous flow regulator. These are very simple. They do not require any electricity. They simply have this regulator on there. You plug your cannula into that and you let the gas flow. This will go up to 15 liters a minute. However, the faster or the higher the oxygen flow on here, the faster the tank will deplete. There is not a battery, but there is a finite amount of gas in this tank. And the faster you run it, the faster it will run out. You'll also notice that this is tall. This is, if you saw from the floor up to here, it's not a small device. The cart, go back down to that, is fairly simplistic. It's like an old school golf caddy bag cart. They can be very difficult to maneuver. As I've done some other webinars and I've done some videos and things like that, I, even as somebody who is in relatively good shape, I was tripping over it. It was falling down. These can be very awkward. And so again, this is that limited mobility that can come up. We're telling people to go out and be active and use your oxygen, and then we're giving them a device that may not be able to suit that need. There are smaller tanks available that can go into a shoulder bag or things like that. But again, the less gas in there, the less time it's going to last. So that's why it is so important to figure out where somebody is, with their oxygen equipment, because if they need, they make some portable concentrators that can deliver higher flows, but those are like the size of a carry-on suitcase. So if you have somebody who is hectic, they're weak, they've lost a lot of muscle mass, and they're trying to drag this cart around with them or load it into a vehicle to take to one of their appointments or things like that, it can be really problematic. And so then again, that leads people to stay at home, reduce their activity level and everything else. So you really have to tie all of that together and make sure that you're giving the person the right equipment for their lifestyle. The last point I want to touch on is the idea of we need to have a lot more innovation. Just like Susan mentioned, the need for a lot more research. We need to really start hitting this a lot harder on the technological innovation side. The pressure swing adsorption technology with the zeolite crystals that's at the heart of these two devices is literally decades old, and that hasn't really changed much since the 1970s. We've had advances in electronics and compressors and things like that, so the devices can be more efficient and last longer and things like that. But there's only a physics, as you can maybe tell I'm a bit of a Star Trek fan, and as Mr. Scott was always fond of saying, you can't change the laws of physics, and there's only so much that zeolite crystals can do. So fortunately, there are some technologies out there that seem promising with ceramic technology and a few other things that we hope to see start coming online, or at least in a research pathway in 2026. But it's really important that we encourage as much technological development in this section as we have seen in so many other sectors of our economy and our society. So hopefully that's a decent enough overview. Again, really making sure that the equipment fits the patient and their skills, their capacities, their lifestyles, their goals, all that sort of thing. Most importantly, remember that each device is a little bit different. And absolutely most important, please remember that pulse dose delivery is not the same as continuous flow. So thank you. We'll hand that over to Dr. Upson.
So Medicare oxygen reimbursement switched over to a competitive bidding program, and starting in 2011, equipment is covered under durable medical equipment, or DME, and the implementation was staggered over from 2011 to 2015, and then it went nationwide. Reimbursement rates are lower with competitive bidding, and the lowest cost modality of oxygen is provided. So for cut out, including education by respiratory therapists and home visits. So overall, the Medicare competitive bidding program aims to control costs while maintaining high quality access to essential medical equipment and supplies. There's cost savings for patients because they bear 20% of coinsurance for payment, and that might be covered by supplemental insurance. It increases quality assurance because only accredited and compliant suppliers win contracts. It has reduced fraud risk because the program vets the vendors and limits the number of suppliers. And there's tremendous cost savings for Medicare. Billions of dollars have been saved compared to traditional fee schedules by promoting market-driven pricing and supplier efficiency. The challenges are that there are thin margins, so the winning bids often come with tight profit margins, making sustainability difficult. There's market consolidation, and smaller suppliers risk exclusion, potentially reducing competition. And this has happened with oxygen vendors. There's operational strain because expanding to cover entire, something else popped up. Staffing and service costs. There are access gaps. Patients in remote or less profitable regions may face challenges in service accessibility. And CBP issues with oxygen have shown widespread difficulty obtaining appropriate oxygen supplies and other respiratory services, especially liquid oxygen. And liquid oxygen allows people to leave the home for extended periods of time without heavy oxygen tanks, especially those who require higher flows of oxygen. And the ATS guideline in 2020, as Susan mentioned, for patients with chronic lung disease who are mobile outside of the home and require continuous flow oxygen rates greater than 3 liters, we suggested prescribing portable liquid oxygen. Because of the problems with the oxygen programs, the competitive bidding program for oxygen was suspended in 2019. The current law states that Medicare must provide oxygen in the home. Portable systems are given if it's financially convenient, but they're not mandated. The portable concentrators have helped a lot of people get out of the house. The downsides are that they're expensive. Most of the ones that we use are heavier than the one that you saw. They have low flow, they need batteries, and as you saw, the settings don't equal the liters per minute. The ones that we give out here, the lightest one is 6 pounds, pulse dose only, so it goes to 1 to 6 liters per minute, and then it moves up in weight and flow, but the highest flow rate is 3 liters per minute. Many insurance companies require that people use tanks first for 3 to 6 months before they'll allow them to get a portable oxygen concentrator. The strengths of liquid oxygen are that it's portable, it's much lighter weight, it has high flow rates, up to 15 liters per minute, and no power requirement for the portable system. The weakness is the cost and the access. As mentioned, there's a thin profit margin, so many vendors don't even carry liquid oxygen anymore. Looking at a 3% sample that was extrapolated for the Medicare system in 2010, before competitive bidding went into place, $14 million were spent annually on portable liquid systems for about 41,000 patients. Near the end of 2020, that had dropped to about $1 million for about 8,000 patients. For stationary liquid, higher amounts, of course, $67 million, and that dropped to 1.6 million near the end of 2020. The number of patients using liquid went down from 32,000 to about 6,000. Another analysis looked at 100% of Medicare data, and it was reassuring to see that the numbers were very close to the 3% sample extrapolation. So by the end of 2021, now there were only less than 4,000 patients using portable liquid oxygen, and it cost less than $1 million. Stationary oxygen, about 32,000 patients, went down to 2,400 at a cost of a little over $1 million, down from $67 million. So in light of the problems that patients were reporting with oxygen accessibility, ATS built the Medicare Oxygen Reform Coalition with many partners. And the coalition talked with Centers for Medicare and Medicaid Services and the federal administration to discuss the oxygen access problems. And the response they got was that competitive bidding is working exactly as Congress intended. A lot of money was being saved. And so they recommended that the coalition go to Congress to fix it. The Supplemental Oxygen Access Reform Act was drafted. It's bipartisan legislation, and it's moving through Congress now. It removes all oxygen from competitive bidding. It would use current payment rates as a base with inflation updates for future oxygen payments, and it would increase payments for liquid oxygen. It would change the terminology from home oxygen to supplemental oxygen, because the goal is to help people get out of the house and live more full lives. It would establish a patient's bill of rights and payment for respiratory therapists as part of the supplemental oxygen service component. It seeks to develop an electronic template to document qualifying blood gas or pulse oximetry saturation data to help determine the appropriateness of prescription. And the Congressional Budget Office, like SCORE, showed that it would cost an extra $654 million over 10 years, which is small compared to the overall budget. So Kevin Dwan and others did a study to see how much of an impact the competitive bidding system did on beneficiaries with COPD. It was done between July of 2009 and December of 2015. And they found that in the first 2 waves of implementation, there were no associated worsened supplemental oxygen use or patient harm. And there was less spending. So if you look at the blue line, the black line is 2011. The first wave of competitive bidding went through to some regions. More regions were added in 2013. And then the yellowish line represents the regions that had not gone to competitive bidding yet. So all group showed fewer new oxygen prescriptions, also about the same for oxygen discontinuation. And they went down in parallel. So there was no significant difference in the decline between the groups or in COPD hospitalizations. There was a big drop in cost. So in the fee-based group, about $750 per month per beneficiary, and the others less than $500 a month. Limitations of their study were that they could not address prescription appropriateness or evaluation of quality and patient-centered outcomes. So they couldn't look at the ease and speed of oxygen equipment delivery, the quality of DME supplier equipment servicing, the provision of education by respiratory therapists, patient symptoms, improvements in exercise capacity, or patient quality of life. They also could not fully measure patient access to supplemental oxygen. They were also unable to evaluate the 2016 nationwide implementation of the competitive bidding program because there was no longer a control group. Everybody was under it. They only evaluated patients with COPD. So we don't know how the program may have influenced outcomes for patients with pulmonary hypertension or interstitial lung disease who often need more oxygen. And it excluded beneficiaries under 65, possibly incurring selection bias and limiting generalizability. And they weren't able to tell how the CBP changed the DME supplier market, which may have affected quality of care. An accompanying editorial noted that despite increasing incidence of COPD, long-term oxygen prescription rates have declined, especially for liquid oxygen. It's possible that this reflects more appropriate or higher value prescribing, less often given for mild to moderate hypoxemia, although for this study, it was before the long-term oxygen therapy trial was published in 2016, so it may not have had as much of an effect. And they noted a concern that removing competitive bidding could reduce overall prescription rates in the long term because costs would go up and insurers, which are separate from Medicare, might not be willing to spend as much. Mandating a bidding process that reduces prices and subsequent reimbursements may disincentivize companies from providing oxygen. So maybe it's better to get rid of the competitive bidding process for oxygen because there won't, and we already have seen that not nearly as many companies provide liquid oxygen. So it's a complex situation. Switching over to monitoring and adjusting oxygen therapy over time. There's an initial prescription, and then patients are reevaluated within 90 days, and then usually once a year. The target saturation is 92 to 95%. Pulse oximeters are accurate to about 2 percentage points, so we want to give a little bit of a safety margin. As of July 2022, initial coverage was limited to the shorter of 90 days or the number of days included in the initial prescription. And that's why we check again at 90 days. It used to be 120 days. Some clinicians have received messages from insurance companies stating that renewals require new ambulatory oxygen saturations. And I live in New Mexico. We're a rural state, and patients often live hundreds of miles away, and it's difficult to get 6-minute walk tests. So now some of our pulmonologists do them proactively every time patients are in clinic, and that takes time and other resources. So the pathway from start to finish, healthcare providers assess for eligibility. Patients accept the therapy or they don't. Decision maker, the payer, accepts eligibility. Suppliers provide the therapy and may or may not involve patient choice in the device that they're given. Someone may or may not provide education. Patients may or may not choose to use their therapy. And someone may or may not provide regular monitoring. And then if these are patients with portable systems, they may progress to long-term oxygen therapy. And lastly, some of the things that were noted in a study of people with interstitial lung disease, There was frustration at the lack of procedural information received before starting oxygen, and including aspects like managing the cylinders and tubing and associated costs. They found that knowledge and ongoing support through a peer or oxygen buddy or health professional provided greater confidence to manage and persevere with oxygen. Patients who received education from healthcare personnel were less likely to report problems compared with those educated by the delivery person or received no education. Peer support programs with sharing of experiences and mutual support alleviated uncertainty and emotional distress. Caregivers reported a need to better understand their loved one's disease and the role of oxygen, with many reporting a lack of understanding as to why oxygen was prescribed and when it should be used. They requested a central contact person knowledgeable in oxygen therapy to be available for patients to contact, and the high cost of oxygen therapy and inequitable access to supply and funding were significant barriers. That's it. Thank you. So,
All right, fantastic. Thank you so much, Dr. Upson. And we have actually 5 minutes for the last, discussion and questions. All these, common problems and challenges with the oxygen therapy. There's a, rather a comment on the Q&A chat from Ms. Valerie Chang. Sadly, it has driven out smaller DME companies, which actually provide a better service to our patients. I mean, I think as a clinician, it's very common that we kind of need to work with patients and DMEs and, lots of back and forth. So I guess there's no other questions. I guess ask, for the panel if there's a suggestion like how to better work with the DME companies.
Is that a question about DME companies? I don't know how to, I think the comment for quality of care, we hear a lot that it's very helpful within an institution or a clinic if they can have a main contact with their DME that they typically use. So there's a single person that staff works with, and it can really improve communication. There's all sorts of things that have come up in various conferences. One clinic had a person follow-up phone call the month after the prescription was given to the patient. So that phone call follow-up by either a respiratory therapist or a nurse or a clinic person. Did you receive your oxygen? Did you get trained? Are you using it? Do you have questions? Another group had a standing phone call with their local DME, I think every 2 weeks, to review their recent orders and say, were they delivered? Were they trained? So that kind of follow-up. It's challenging, but I think every group kind of navigates their own way, but it's very challenging. Yeah, especially with portability. I mean, I've had patients tell me, "Oh, I got to know so-and-so with this DME. I drive over there every Friday. I go around the back and they give me extra e-tanks in my trunk." And I'm thinking, oh yeah, I've got e-tanks rolling around your trunk. But that's the kind of things, for patients who believe portable systems help them. These patients with exertional hypoxemia only, some really claim benefit. It's hard to match sometimes what we clinically hear from our patients to the studies that are published. It's how do we capture that? But DMEs and equipment, challenging. Some are very good. Some patients, find their driver is wonderful, they're dependable, but others we hear not so good. Varies.
Thank you so much. And I think this will be the last question. Okay, in ILDs, is there scientific evidence of the cumulative effect of short periods of desaturation as it relates to developing pulmonary hypertension?
Yes, we don't have the answer to that. That's what we need. So I think the question is, for example, if you have ILD and you desaturate, you exercise an hour a day, or you are in activity levels, a couple hours a day, and only desaturate during that time, does it lead to pulmonary hypertension? We don't have the answer to that question. We only have the answer to chronic resting hypoxemia. Do we want you to be dropping down into the 80s or high 70s during the day? No, not for an hour or any time. But we don't have evidence to say what the outcome is in terms of pulmonary hypertension, survival. I don't know, Dawn, I don't know if you have anything to add. That's the data we need. And that's why, like what Dawn did, she did this sham thing, but that, we want it longer period. And it's hard to study. So my answer is that we don't know, but you should use your oximeter to check your pulse oximetry readings and avoid being low, but we don't have scientific evidence of specific outcomes. Not a very great answer, but
no, I don't know any more than that.
Yeah.
Well, I think it's 4 o'clock and time to wrap up. So, I'd like to thank our speakers, Mr. Jacobs, Mr. Hess, and Dr. Abson very much, and all that joined in this webinar, asked questions. I also would like to thank the ATS, AII, and CP assemblies for joint sponsorship for this webinar. If you have suggestions for future speakers or topics, please contact your ATS assembly representative. And with that, we'll conclude our webinar. Have a great rest of your day. Thank you so much.